Welcome to a special episode of the Tate Chronicles. I'm your host, Jim Tate, and we are live at ViVE 2023 in Nashville, Tennessee. I'm joined by an illustrious panel today, and we'll have them introduce themselves in just a minute, but I want to thank Chime and DHI for inviting us to their theater located at ViVE Central. Bevey, please introduce yourself and tell us why you're here.
Thank you, Jim. So I'm Bevey Minor. I am the EVP of Healthcare Strategy and Policy at Consensus Cloud Solutions. To give you a little bit of my background, I've been in this business for 20 years trying to solve interoperability. And our panel today is trying to figure out, really where are we still finding the challenges, because otherwise we would have solved it by now. So I'm excited to join the rest of this group and my moderator here to figure out if we can just at least discuss what some of those hurdles are. And if I see shaking heads in the audience, I know we're hitting on some topics that you all agree with.
Great. Scott?
Hi, my name is Scott Stuewe. I'm the president and CEO of DirectTrust. And DirectTrust is an organization that basically supports the exchange of healthcare information by enhancing the trust that the individuals in the ecosystem can feel about that, about their trading partners. I've been in business since 1991, so long enough to know better. My first part of that career was actually as what they used to call an interface person. So I did a lot of, arguably the first kind of interoperability that there was. Interoperability being defined as something that would be across a business boundary. We were doing lab-to-lab interfacing in 1993, and that's kind of all there was in the way of interoperability. Other than that, things were all inside the enterprise. And so interoperability is a really relatively new thought. But it is also, even though we've been at it really hard for the last 10 to 15 years, we're still a long way from where we want to go.
Michael?
Great. Hi, I'm Michael Parisi. I'm formerly with HITRUST. Recently left about 2 weeks ago, and now I'm with Shellman. And I've been in the interoperability space for over 20 years. And everything that Scott and I have talked about throughout the years around stakeholder trust is really what I'm passionate about. So I look forward to the discussion today.
Well, thank you. Our topic today, Achieving Interoperability, is adoption, our last hurdle. And let me first say all comments are my own and don't blame anybody else. We've been on the road to seamless exchange and use of healthcare data for decades. Everybody says they want it, yet challenges still remain. Is our vision of true interoperability only a mirage due to all the barriers of success? Will we have to settle for interoperability light? Healthcare information transfer evolved in an environment that was the antithesis of interoperability. This lack of interoperability is systemic and cannot be fixed by technology alone. ChatGPT will not take us to the promised land. So the first question I have, Bevey, is going to be really directed towards you. Can you tell us and talk about some of the inherent workflow challenges that have impeded clinical data exchange over the years?
Yeah, I think the way to really think about this is we're all patients in this system as well. And we're caregivers sometimes. So when you think about a patient that is in an acute setting like a hospital, and they move through the system to a skilled nursing facility or home health or assisted living, there's a continuity of care that we have to offer those patients. They deserve a seamless continuity of care. And when that's broken, the health outcomes are broken as well. And so when you look at these workflow challenges, you've got nurses that are sitting there doing data entry. They're not operating at the highest level of their skill set. They didn't get into the business of being a nurse or being a doctor so they could sit and data enter. a bunch of information, a bunch of patient demographics because the data doesn't flow seamlessly. And when that happens, you've got errors because data entry can be prone to errors. You have latency in care. And what we really need to get to is a system that starts to recognize that data will be unstructured. That's not the problem that we need to fix all of a sudden, is that data should be completely structured. It's not going to happen in our industry. But what we do at Consensus Cloud Solutions is recognize that there's a lot of unstructured data, and through our solutions and our products to be able to enhance and transform that data into a structured type of a format, it can be received at that point of care so that no human has to data enter that. And that really helps with the workflow challenges, because we're also seeing huge burnout because of this problem as well. And that's what I hope we start to achieve, is to get to that kind of a vision.
Thank you for that. And let me just mention, even though I may direct a question to one of y'all, if anybody else wants to add in a conversational way or has some input, please go ahead.
No, I won't let them talk.
Okay. But since I got you on the hot seat, Bevey, let me throw another one at you. The pandemic highlighted an even more important focus on improving care coordination for patients. So what are some of the ways AI and other technological advances can support this type of care coordination?
So I'm glad you asked that, Jim. I mean, headlines are all over the place about what the pandemic did to magnify how bad interoperability is. And
Yes.
it took an unfortunate incident like this to show where we have pieces that are broken in the system. And I'm reminded of a photograph that ran on the front page of the New York Times early on in the pandemic, where Harris County showed there's a fax machine and 4 feet of paper right by the fax machine for Harris County. What was on those pieces of paper were COVID lab tests, positive, negatives. That had to be data entered somewhere. The state of Washington hired the National Guard to do data entry for COVID tests. All of that was just unstructured paper documents that were really tracking where the pandemic was at its highest levels. And that's magnifying it even greater than it is in that one particular incident. But wherever you see paper, and I've asked CIOs of hospitals this over and over again, do you have a paper problem within in terms of sharing information within your hospital systems? And they, oh no, we got rid of all the fax machines. Well, walk around the hospital. Wherever you see paper, a stack of paper at the nurse's station, in the HIM department, stacks and stacks of paper. Something has to be done with that paper. So the pandemic just showed us that we aren't speaking to each other. We aren't communicating the right way. Patients end up in an emergency room. They end up in an acute incident because of COVID, and they're discharged to who knows where. So I think it was an unfortunate situation, but it definitely got us to start thinking about this in a more collaborative and alarming way.
Well, I also think, they say, don't waste a good crisis, so it's really been very useful to get people. So the biggest challenge, I think, in the workflow setting for healthcare interoperability is that people don't even know they're connected. They don't even know what they have.
Right.
And that is the one thing that the pandemic helped people realize is that how can we possibly send this information? Like, how do we do it? Can we do that? And they find out that, they actually have a mechanism that they can use. And they used it by the millions of transactions. They use direct secure messaging to send information to APHL, which is the Association of Public Health Laboratories, which was a router that could then forward those transactions to the appropriate jurisdiction. That was a huge benefit, but people didn't even know it existed. It was actually being built over the course of the 3 or 4 years prior to the pandemic. I mean, the APHL and all that stuff was in place. And so is the direct secure messaging environment, but nobody knows that they have it. And this is actually not unique to direct secure messaging. So if you are a patient and you have any experience with this, just go and ask if they can get a hold of the records from the other place, even those that are ostensibly connected to Care Quality or Commonwealth or both, or to the HIE or all three, and have direct secure messaging at their fingertips. None of them know they have any of those things. They say, that's just not how we do it. So it's getting people aware is made more possible by use cases that are intensely important to the society. So like getting COVID communications made people aware of the fact, and during that time we had huge transactions volume in both the direct secure messaging network and the query networks, where everybody's like, for God's sake, let's use this because we're not going to see each other in person near as much.
I think to those comments, complacency is really what killed interoperability prior to COVID. And now you got to stare at it in the face, and you got to leverage, I think to Scott's point, things that have been in place for a number of years.
That's really true. On this stage yesterday, I was Dr. Nash, who's written a book called How COVID Crashed the Healthcare System. And, kind of going back through the whole thing, and I recommend that to anybody to read. I've been involved with hundreds of EHRs going through the certification process, and in every case, they had to have functionality for public health surveillance, immunization, and they always said, why do we need this? I said, well, if there's ever an epidemic, we'll be ready. We had the epidemic, but nobody knew how to use it or what to use it for or anything. Michael, let me ask you, why are consistent, standardized, and transparent data security assurances so important to ensure the success of interoperability?
So I think we need to have a consistent bar that we're measuring all the stakeholders within the interoperability equation. Transparency is key, right? When we look at the protection of data, sensitive data, and when we think about, as Scott and I talk about all the time, stakeholder trust, you need to have a level of transparency relative to cybersecurity and information security as it relates to the sensitive data. The problem that I think we've seen for a number of years is that there is no consistent bar that organizations are measured against. And when we think about interoperability, and I think later on in the conversation we're going to talk about participants and sub-participants, right, as part of the TEFCA equation, they're the weakest link. It's not the QHINs, right? The QHINs are the ones that are being held to the highest standard. So we need to ensure that everyone as part of that interoperability equation are held to a consistent standard, and transparency is critical. It's not just about a checkbox exercise relative to information security. It's making sure we understand how mature those programs are in order to ensure stakeholder trust as part of the equation.
Something that was mentioned a couple of minutes ago, when we had the first federal incentives for the adoption of certified electronic health record technology, a lot of money was put into the regional, the RECs, regional educational, wherever they were, to go out and help implement those
extension centers.
Extension centers, exactly. For the interoperability piece, maybe that we don't have that piece. People don't know what they have or how to use it.
Well, Jim, I think just to add on to that, we left a lot of stakeholders out during accountable care. We gave the money to the physicians to be able to adopt electronic health records. We didn't consider the skilled nursing facilities, home health. We didn't even know an acronym like SDOH even existed. And those care settings today are the ones, to your point, Michael, there's a bar. We have to achieve that bar, but they were not a part of the measure set.
Right.
They're not incentivized with MACRA or MIPS. They don't have a certified EHR. And we've got to get to a point where we look at all of these different care settings. The ones in critical access hospitals, Direct is a great way to be sharing that information. They don't know what they have. And, I think one of the most probably most punitive actions that CMS took was the ADT notification rule.
Yes.
A year ago in May, CMS said every hospital has to notify the downstream physician team. And that includes behavioral health, that includes critical access hospitals. And some of those care settings were like, we don't have the technology to do that. Nobody gave us the money to be able to do that. So we've got to figure out how to work with our regulators, our lawmakers, and CMS and ONC to incentivize that universal standard, as well as be able to look at interoperability that can be universal. But it's not going to happen if we don't incentivize those different care settings.
So, Betty, I think you're right that there's some aspects of the ADT rule which are, this is actually not atypical. The government thinks of half of the story. So the government got very good, so they require that, first of all, they did not specify a standard for the model. So actually we worked to create a standard that the EHR companies came to us and said, help us, we need to have a standard here for communicating this stuff. So that was done, and that made a difference. But the problem we have is that in general, the government's really good at telling people how to send things, but the obligation to receive is not present. And so that you can't have, one hand does not clap. So if you don't have somebody who's actually expecting the message and handling it in a way that will work for their users, a lot of the burden that we see is in that when the certification program was established, there were no expectations around what the end receiving system did with the message that they received. And so as a consequence, it just was a burden. It just ended up being in their way, as opposed to being something that could be very useful if in fact it could get routed to the right person, the person who cared about the message. Most of the messages in the direct secure messaging ecosystem are of value to someone, but the people who are getting them are not the people for whom they have value. So that's a problem we need to address, but the government didn't help because they didn't actually put any standards or requirements on the receivers, only on the senders. So the same thing happened with ADTs. They didn't tell you how, they didn't tell you what to do when you got it. Hospitals had the obligations, nobody had any obligations otherwise. So that makes it very, very complex. But the good news is that there are things that we can do, but I think in the adoption area, the subject of our discussion today, if we don't if we don't pay attention to the educational requirements, one of the things that the RECs did back in the day was they actually did the work of helping people figure out how to use these things. Right. And there are no agents of that sort in the marketplace today, zero. So we try and play that role, but we are a small not-for-profit trade association, and this is a mass market retail problem. There are thousands and thousands of organizations all trying to make sense of this. We can't communicate to those thousands of organizations ourselves. So I think a gap that is the biggest problem we've got is education is the gap. Like the technology is actually there. Right. If they knew how to use it in a sensible way and configure it in a sensible way, then it could be valuable. But in the way it is, in many cases, it's not valuable. In fact, in most cases, it's not even visible.
The adoption of certified technology, meaningful use, the MAC or MIPS program all involves incentives. Are there any incentives for interoperability? Do there need to be?
Well, I think what you're starting to see, in fact, we're in a period right now of notice of proposed rulemaking, 2 rules that are going through CMS right now that have the incentives. They've got incentives for MIPS, but again, those incentives are usually tied to a certified EHR because you have to have some way of determining whether you met those incentives or not. So, our regulators are famous for the carrots and the stick. I worked at Allscripts back in the day before we even had EHRs, and I was pushing hard for electronic prescribing. Competition was a pad and a pen. And the physicians didn't realize that just a decimal point could mean life or death for a patient, right? And we gave it away for free at Allscripts. until we ended up with incentives that said you will get 2% more reimbursement from Medicare if you do 50% of your prescriptions electronically, did we see any real movement.
Yeah.
And then when the stick hit, which is you'll have a reduction of 2% of your total Medicare claims filings, your claims amount, did we see hockey stick growth? So, I mean, it's unfortunate, but when you really look at the systems, they operate on very small margins. So pay me more. I mean, it's not that it's not an altruistic. Everybody wants the patient to be treated better. But when you're looking at, the ways that systems, hospitals, and other stakeholders need to keep their doors open, it's like either reduce my amount I'm getting reimbursement for, or give me more, and you'll start to see some of those movements.
I think the regional extension centers were paid somewhere between $4,000 and $5,000 for each practice that they got for adoption and some meaningful use. Larger practices, maybe more. Scott, where does trust work into all this?
Well, I think so. There's several aspects of this trust. So Michael mentioned this notion of stakeholder trust, that the stakeholders need to understand that they're being held to the same bar from a cybersecurity, cyber health standpoint. I think that's one aspect of it. The other kind of key aspect of it is actually identity trust. So trust that you know who you're talking to. This is actually much more important today than ever before. So in fact, I'm personally of the opinion that what we need is a veracity engine. Like, what is it that tells me this is really who they say they are? What is it that tells me that, like, I wrote this, that this is a contract that you and I signed, that this is, we have technologies to support this. We do not have adoption of those technologies. So digital signature supports that very effectively. If I want to say that a person is who they actually say they are, there's no reason that you couldn't actually have literally a cross-platform mechanism to say, this is me, as opposed to Meta saying, oh, for $8 a month, you can be, identified on, on the system. Actually, that's not Meta, it's Twitter. But in any case, that whole notion of trust and identity is essential. Today, like for digital identity in healthcare and just actually in general terms, the technologies are available and we're already using them, but the policies aren't in place. So like we use this capability today, log in with Google, this is enabled by OAuth. Okay, so this workflow is what they're talking about TEFCA using for individual access services. And it could work, except that you're in circumstances where you don't necessarily have accounts at both places. You've got records there. You only went there once. You never got a portal account. So in order for that health system to trust this caller who has never even had an account at that system, a very much higher bar around identity has to be established. And that's an element of trust that I feel like is really important for us to figure out. And the identity industry is very, very early. So it's a very, very, people think of it as being something that we've had for a long time. It's not. This is all brand new stuff, and it's changing really rapidly. So I think that's a big element we haven't talked about.
One thing about trust that I wonder about is if a provider 2 years from now turns on that TEFCA faucet, data comes down on a patient, how willing are they to trust that data that comes down? I'll give you an example. Current pharmaceutical insurance coverage, there's a diabetic medication that has a side effect of weight loss now. Everybody, a lot of people go, give me this for weight loss. And so their insurance will cover it. Their provider has to give them some type of diagnosis or pre-diagnosis of diabetes to get coverage. But that makes you wonder how much you can trust the data that's coming down. And one other thing I'll say is, and you touched on it a little bit, Scott, that you actually trust that the data you're getting is on the patient you're inquiring about.
Yeah.
That patient matching aspect. Where are we with that? Is it safe yet to go in the water?
It's actually not that unsafe. What it is right now is just not very. It's not very convenient. So right now we are like you can get an app and get your records today, for the most part, actually from any certified EHR. That's actually a thing. It really is. But you got to have a username and password from every single solitary place. So they know it's you. Now, the thing that's, I think, really interesting to figure out with you, the specific question you're asking is, how do you get the patient plumbed into the decision-making process about whether their records are accurate or not? Because that is actually not a thing today, generally. But it happens all the time. Like people will look at their records and say, "I never had that procedure." Like this stuff, and it is actually a real problem. It could be a real problem if your records are incorrect. So getting that trust level up is going to require a patient engagement that today is not really a real common thing. Patients don't engage at that level generally with their health records. They may want to, but mostly they don't. When they're healthy, they don't care. They get really sick, they don't understand their records. They're really complex. So it's the one area where you really get a lot of value is in the places where people are managing chronic conditions. That's when they engage, and those are the ones that are going to say, "I never had this condition. That's not even the medication I'm on." Those kinds of things. They're the best equipped to keep the health system honest, and the health system has no mechanisms to go back and check to see if something is correct.
Well, I think what's also interesting is that when you look at some of those chronically ill patients, it's the unpaid family caregiver that knows what exactly happened. And I'd be interested to find out if you really think that helping to solve this problem will be patients' access to their data, because it's part of the 21st Century Cures Act. It's supposed to have, even payers have to populate these things. What I do like that CMS said is we're not going to prescribe how patients are going to get access. Vendor community, innovators out here, figure out what kind of apps, go on a smartphone, but we're telling the system that they have to populate that data, including the payer. What I'm interested in is, are patients really going to use it? I think the ones that might, and I'm hoping, is because I have been an unpaid family caregiver for, a sick, chronically ill, father, and just trying to get his records so I could help navigate his care was extremely challenging. My dad didn't know what meds he was on. He used to carry a little index card that had all of his meds on it. It was dog-eared and faded, and it was out of date the very next day when he saw a new physician. So I'm hoping that at least access to the data will mean that we can help promote it, especially with, the best quarterback for care in these chronically ill patients is the family caregiver.
Yes.
Yeah, I think that's a great point. I think, unfortunately, it's the exception and not the norm, to your point, Bevey. People just don't care as individuals, right? They don't understand the data. They don't understand this concept of making sure that it's accurate and complete. I think Scott's point, is spot on. I can't tell you how many times I've heard from people that when you look at their medical records, it's inaccurate. They're being billed for procedures that they never underwent, right? Medications, inaccurate. It shouldn't be this hard. And health systems, back to your point, Jim, around incentivizing, we shouldn't have to incentivize them to deliver accurate care.
Well, and if that data is not accurate, then you really can't trust the clinical decision support rules that fire.
Correct.
So, that's part of it. Well, let's talk about TEFCA. So, we had the RIOs, Regional Health Information Organizations.
The chins back in the day.
The chins, okay, you're going back. The HIEs, Health Information Exchanges. TEFCA, really part of legislation, 6 years, tens of millions of dollars have gone into it. If we can't have a nationwide health information exchange, a concept of a network of networks, to me it's kind of like different phone systems. You can call any phone from any place else, and there's something that makes it all work. So this is a bold initiative. So what do you think? Is it going to work?
You first, Scott.
All right. Well, so perhaps famously, you'll know that I'm a skeptic in the TEFCA camp, to be perfectly honest. However, and the biggest reason why I feel that I'm skeptical of TEFCA, not because of what TEFCA will do, but because of what it won't do, and what we know it won't do, because it doesn't have any plans for it, is to solve the adoption problem. So it's not, it might make more small rural hospitals able to connect. That might be a value proposition for TEFCA. As I look at the pros for TEFCA, I think, has the potential to make it more likely that the 4 in 10 hospitals who are not yet connected to a national network get connected. So if that's the case, it might be good. But what it doesn't do is solve the problem that I actually believe is the biggest problem, which is that people don't know that they have it and they don't know how to use it. So if TEFCA has literally no plan for that. It has nothing to do with TEFCA, right? TEFCA is about laying track, which, by the way, is parallel. I think of this as, okay, we had Route 66, we put in I-70. Like, I'm telling you, these are connecting the same places. So it's initially, you're not getting a lot out of it. Now, if what it does is force the mode into a FHIR-based exchange mode, I think that could be interesting. But there isn't a strong incentive to do that either. So it's sort of if we build enough of it, then they'll start using all of that for other things idea. And so far, I have not seen that will necessarily work. But it's I think Mickey is actually pretty transparent about what he thinks about this. I think he believes that it has potential, but he also is self-aware. This is not a silver bullet. This won't, unless the industry actually jumps in and adopts it and utilizes it to its full extent, it won't have a huge impact. That's my 2 cents.
As one of my good friends says, it briefs well. TEFCA briefs really, really well.
Yeah.
But I think Scott is spot on. There's still an adoption challenge, right? Is it going to be used from a care delivery perspective? And to your point, Jim, is it going to be trusted, right? The data that's coming from that. I think we've seen challenges from a delivery perspective across our healthcare system for years. The behaviors are still there. So back to Bevey's point, how do we train and educate to make sure that those behaviors don't continue, and use what's available from a resource perspective delivered through TEFCA and interoperability in general?
I'm sorry, go ahead, Bevey.
Well, I think when you look at TEFCA, we've been around this, we've got to get to a standard for 20 years. And we didn't have the capabilities of doing that because we just didn't have. I worked at Citicorp during the days where we were trying to get interstate banking passed and ubiquitous access to your money. And so I've heard an analogy to this before. But back then, Citicorp and Chase were the 2 leading banks. They created a standard for sharing that data. Mm-hmm. We had the Social Security number attached to every person doing your banking. Anything you do financially is your Social Security number. And then we needed to have, the ATM. And ATMs were only in individual banks. But now, fast forward to today, and no, I'm not saying it's a completely, unpenetrable problem, because we see it happen all the time where your financial records are hacked, etc. But at least you have ubiquitous access anywhere in the world. You can find the balance in your bank account, and you have that ability to share that information. You can look at your credit report and determine, is this really accurate? Mm-hmm. Did I take out that loan? Do I really still have that balance? And it's easier in that industry because it started with standards and it started with an identifier, right? And we haven't gotten there yet. So I think TEFCA lays the groundwork for a movement towards a standard. And look, we all want to get to structured data at the end of the day. We want that data to be consumable. To your point, this is a receiving problem, not a sending problem.
Yes.
And we want it to be consumable. We want it to be actionable. and we want it to be validated and trusted. So it's a framework to be able to do that. But I've been here before. I've heard of this before. I mean, X12 has been around forever. Right. We were pushing X12 as the standards forever and ever and ever. So, I'm hoping the new conversation, the pandemic, everything else will get us to a point where we start to realize we have to start to adopt something, right? So
I like your analogy of the banking system. 17 years ago, I was in Beijing in the Forbidden City, and there was an ATM, and I went over there and put a card in it and got American money out of it.
Amazing.
Yeah, I mean, and boy, there was trust obviously there's trust there. One thing about TEFCA is the requirement that is backwardly compatible with existing HIEs or whatever is out there. A concern I have is larger practices and hospitals will be able to do the technology and adoption around TEFCA because they have the bandwidth and the money to do it. Yep. The smaller practices, 2 or 3 people, whether urban or rural, doesn't matter, they really can't even do a security risk analysis themselves, a thorough one. And so is the digital interoperability gap going to grow?
Well, I think there's a gap, and we have to recognize it. I mean, like I've mentioned before, home health as an example, they're not all of a sudden going to, put in a lot of digital workflows. They're barely off of 3-ring binders, and I still think they're on 3-ring binders in the home. So I think, it's about not stifling innovation. Let the vendors figure out how to be great partners. And that's what we do. We've got a lot of skilled nursing facilities, home health. Our flagship product is eFax, digital cloud faxing solution. And it's got this bad F word connotation, but we recognize that 4 billion faxes go through our system and for healthcare. And if we can move that data to a TEFCA framework, we don't have to put those hurdles in place because you're just going to find those. We're discharging patients from the hospital at much sicker and acuity levels than we ever have before. Their treatment is going to happen in places that are not that interoperable. And we've got to get them to be able to have the capabilities or to know they've got it already using Direct.
Right.
If we really want to solve this problem from end to end and make that receiving problem, go away. And I do believe that, TEFCA is it's this one size, and we have to recognize that the end game is good. But how are we gonna make sure that to your point, all of these more unsophisticated care settings can be able to support a framework like that?
Well, the other thing, I think, to your point, that the costs of doing some of these things are going to be difficult for some of these organizations to bear. In some marketplaces, I'm aware of activities in New York, for example, where they're trying to figure out for these SDOH targets, these, whatever you want to call it, the community-based organizations. Community-based organizations like food banks and the homelessness management information systems organizations. These organizations are very much smaller, very much less technically astute, have very, very small budgets. So how do you give them enough money that they can do what's actually needed to ensure their participation in a network of networks? I mean, it is really hard to do, and you can't. I think you do need to make it right size. You have to come up a way with assessing a food bank that doesn't hold them to the same requirements of a three doctor practice. It doesn't make any sense to hold them to the same standards, but to hold them to no standards, if in fact they're being connected to this network, is not good either. So you got to figure out what that standard is and create a tailored approach to hitting that market and working right with that group. I think actually also that's true for small practices. Like the 3-doc practice is way different than a health system, and yet the problems are the same for sure. Like the risks are the same. Like that the organization's systems could be taken offline by a phishing expedition or an attack of any other kind. And those things are becoming all too common. In fact, healthcare is the number one target for identity theft and for cybersecurity incident because, well, for two reasons. One, they're so ill prepared. They're like an easy mark, okay? And then secondly, there's an awful lot of great data there. Like, health data is rich, and it's everything that you use to bill, and you have to share that everywhere you go. So all of your doctors have all of this information about you that is eminently hackable. And so getting everybody to the level where they're trusting each other is going to require everybody to be at sort of the same bar.
So, few comments on that. I think when we talk about risk, we need to understand the inherent risk that an organization introduces into the equation. To Scott's point, everyone's going to introduce some level of risk. Some organizations are going to introduce more than others, but there needs to be a minimum bar relative to inherent risk. I think to Bevey's comments, our vendor partners have figured this out. Like, if we work with the right partners through inheritance, shared responsibilities, right? Those types of concepts, it's already there. Also, to Scott's point, when you think about healthcare data from an industry perspective, we're really playing into significant emotional events from an individual standpoint. I don't know another industry besides maybe travel and leisure where we're dealing with the highest risk in the world. We're talking about the loss of human life, right? If this data is not protected appropriately and if it's compromised. So understanding the risk and caring about the risk that these organizations introduce into interoperability, the TEFCA equation, is really, really important. And without that minimum bar, I'm scared in terms of what can happen.
Yeah, I think that one of the biggest use cases that we're starting to magnify is our whole prior authorization process.
Yes.
Right?
Yes.
And even in the latest proposed rule for advancing interoperability and prior authorization, CMS is trying to, put a lot of the onus on the payers to, you've got 72 hours. You have to approve or deny an authorization. And when I talk to my neighbors or at a dinner party and I try and explain, well, what are you passionate about? What are you trying to do? I say, have you ever tried to wait to get your MRI for an ache you have in your elbow? Well, you're yelling at the doctor's office and you're like, why can't I get my MRI? This pain is not going away. And the doctor is frustrated because it's not his problem. It's that he can't get the authorization from the health plan. And the health plans are bogged down. 40% of medical prior authorizations are still a manual process. At least we've got EPA for prescriptions, better. But this is human life. That's a problem.
Right.
And I have a family member that, waited and waited and waited to get an authorization to see an oncologist, when all the while the only thing the plan would approve was PT. Finally, when he got into an oncologist, authorization to get a chemo bed. Every single solitary time he needed to go on another treatment for chemotherapy. And this is human life we're talking about, and it's not a problem that the stakeholders, are really, they want to solve it. Everybody wants to solve it. The physicians don't want the patient yelling at them. The patient doesn't understand, why can't I get treatment? Everybody wants faster treatment. We know that leads to saving life and better health outcomes. It's the system that's the problem. And whether rulemaking can get us there or data that needs to be structured so it doesn't have to have data entry, there's a lot of different, models that I think have to come together to really solve our prior authorization problem. But at least we're magnifying it more and more and more. And that, if we can solve that use case, I think we can do a lot to advance interoperability.
Shouldn't be this hard.
It should.
Well, so let's talk about the architecture of TEFCA a little bit. So we've got these QHINs, the Quality Health Information Networks. 6 of them have been announced that they can go into the testing phase by the end of the year. Maybe some things more in the pipeline. You only need to be connected to one of them, and you're connected to all of them. It's just like the phones. Underneath those QHINs are participants. Those participants could be healthcare developers. They could be EHR vendors, could be a bunch of different things. Underneath them will be the sub-participants, who could be the providers. Somewhere in there are the individual patients, because there's the individual mandate. I don't know how that's going to be billed. Is it third parties are going to create apps for me to access? What do you?
So the question is, I'm sorry, your question is what? How are the apps going to be billed?
Are there going to be apps for individuals?
Well, yeah, apps for individuals are so separate from TEFCA.
Right.
Apps are a requirement under 21st Century Cures
Right.
at the very beginning. So in the information blocking rule, that's where that lives, right? And there's actually a fair amount of specificity about what they actually have to do. So they have to, EHRs have to provide a capability, and it's in the certification rule as well now, that they can put up their Fire server and make it possible for apps to get hold of data, and that has to be at no cost to the patient. And someone will pay. It says nothing is free. So let's just make sure everybody understands that. Like it must be free. Like nothing is free. So that's. I think how's it billed? The patient won't pay anything. Someone's going to pay. Probably the provider.
And so I'm just curious how this is going to work out. So will a EHR vendor select a particular QHIN and then have a TEFCA button in their application?
So it'll look lots of different ways.
The providers are probably not going to connect directly to a QHIN, do you think?
It will vary. I think it actually is going to depend on what an EHR vendor does.
Right.
So like if an EHR vendor determines that as an EHR vendor it intends to be a participant in a QHIN, then its clients will be sub-participants. And I think that would be pretty common. That'll be the common case. There's also going to be some unusual circumstances where EHR vendors are actually the QHIN.
Like Epic is
Epic
is a QHIN.
So and that may not
And
be
Cerner
the
is going to be a
case.
participant.
Cerner will be a participant under Commonwealth, likely. That would be the expectation, or Oracle, as the case may be. But that I think there will be a fair amount of, even though there's a pattern for how they have to kind of string together, the business relationships will vary.
What do you think? The Epic QHIN is only going to be for Epic users? I think they'll. No?
No, I don't think it will be. The real interesting play from a QHIN perspective, and when you talk to these organizations that are going through the process, most of them are not charging to connect to their network. The value that they see is the data. As they have access to the data, when you think about the add-on capabilities that they can sell to the participants and sub-participants, it's all about the data analytics.
Well, and that's one thing. I've interviewed folks from almost every one of the QHINs, and one thing that struck me is all QHINs are not the same.
Yeah.
Right.
Yeah, if you've met one QHIN, you've met one QHIN.
Right.
And so let's talk about the differences, maybe not by naming them, but some QHINs are going to be the minimum daily requirement, where you turn on the faucet and something comes out. I'm not even sure what's going to come out. What's going to come out? CCDAs or what's going to come out at a minimum?
I think initially it'll be CCDAs, because that's so they're using the IHE profiles, XCPD, which is the cross-patient. You're basically going to ask, do you have my patient? And the next question is, can I have their records? So it's those two transactions are in broad use today in the Commonwealth Care Quality ecosystem. And what's interesting for me, I guess, as I watch how this unfolds, is how the care quality ecosystem will devolve into the new TEFCA ecosystem, because there are participants, there are there are care quality participants who will not be QHINs.
Right.
And so where do they go? Because today they are peers of the other care quality implementers. All of those people are going to have to find a new home, because they're not care quality is not a home for them anymore. It would basically mean that they have to find a QHIN to hang under, and that's a new relationship for them. So I think that's, from my point of view, I see this as watching a really fascinating thunderstorm.
I know it.
It's like, God, it's not predictable at all how it's going to work out.
It sounds like reality TV.
Yes, yeah, exactly.
Who do
a
I
lot
want to
going on.
date and who should I be with?
That's right.
And,
I think to
you know.
Jim's point, how do you select a QHIN? What are the differentiators? That's evolving, right? And without naming any
Right.
specific names, there are some that are doing a very good job of differentiating themselves.
A lot of value add
Yes.
that they are doing to massage and clean up the data.
That's right. That's right.
I don't know. I can't wait to see what it looks like when it comes out. Is it going to be a meatloaf, or is it going? Yeah.
And in addition to that, Jim, I think another differentiator, bringing it back to security and privacy, is how much they've invested within their information security and cybersecurity programs. That's a huge differentiator. You have some organizations that are going down the QHIN path that say, well, I use a vendor partner that maybe has appropriate cybersecurity programs, and therefore I'm covered.
Right.
That doesn't work, right? So making sure that not only are they responsible relative to the vendors that they're choosing from a security perspective, but do they have their own shop in order as well? And that's a differentiator.
Yeah, policies and practices are important, as well as the technologies and the tools that you lay on top of technologies. In the absence of an evaluation of policies and practices, you don't have a good understanding of what their protection levels are.
Right.
And so organizations need to be, the QHINs are held to a very high bar. At this point, there's no obligations that are in TEFCA for cybersecurity health of participants or sub-participants yet. So the question is that right? Is that wrong? The QHINs may be actually resistant to those obligations, because it then asks of their participants that they have a new cost. Okay, so it might make them, if one asked for that cost and the other did not, then it's a competitive problem, right? So I think it's going to be interesting to see how it shakes out. But I do think in the long run, minimum standards will have to be set, because I don't think if you don't set them, then they'll use this as a competitive edge. Like, we're cheaper, but of course we also don't ask our participants to do anything in the way of any kind of independent certification. So leaving that to the market will undeniably send everybody to the bottom.
And I also think that there's so much confusion. We have a new acronym. Healthcare is so full of acronyms that as I talk to some of our health system, they're actually asking me, so what is all this? And CMS is kind of notorious for not doing a lot of the education. You can go out to their website and find the white paper, the press release, and everything else about it. But it's, how do I participate? Do I have to participate? Am I going to get greater value out of it? I use Carry Quality already. I do queries for that. There's a lot of open-ended, questions. And I think also what was pretty telling in this latest proposed rule is that, I don't know, for the advancing interoperability and prior authorization, when there were close to 1,000 comments, nearly all of them said we have to slow down and we have to test and we need implementation guides and we need to have Sequoia do much more to tell us how this is really going to play out. You're talking about, patients' lives in the middle of this stuff.
Right.
So I wonder how fast it really is going to accelerate unless we get some of those real examples. And, we've got the first 6. I'm glad there's only 6. Let's see what happens in 2024, 25, and 26. Because I think it's going to have to play out in real environments to see where we're going to net out.
Well, and we may see, maybe not the first round, but in the second or third round of QHINs, somewhere down the road, some folks are going to be dropping out.
Yeah.
Yes.
Yeah.
I hadn't thought about that till just now.
And so
but
what if you invested in being a participant, sub-participant in that particular QHIN? Now you have to invest in something else, or where do you go?
Well, I think initially they're trying to, the RC and the ONC, trying to make it possible for this thing to kind of get jump-started with no fuel.
Right.
Okay. So there's, by fuel, I mean funding. So ONC doesn't have funding for it. Except to just stand up ONC, or stand up the RCE. RCE actually is not in a position yet to charge for it. So at this point in time, it's not yet self-sustaining. So the RCE wouldn't have a way to survive if this is the way it was forever. It can't be, right? So once I think that what they're trying to do is let the car get rolling down the hill, and then once it kind of gets rolling, then they can, put gas in the car. Well, hopefully the engine's built, but there's no gas in the car. There's literally there's no fuel for its ongoing action. So I really feel like that's one of the biggest things that is going to be interesting to watch, is how they get those gears engaged, how they get that fuel into the tank, and how does it flow, because it is going to be a very complicated problem.
I think the other thing that we'll see, Jim, is non-traditional healthcare organizations are going to enter into this space, right? For example, when you look at the cloud service providers, I want to put it past Amazon, Google, Microsoft to potentially become QHINs from a data perspective, right? So, obviously we're familiar with the HIEs, the HINs for a number of years now, but this is creating a new market for the tech companies. And a lot of them, from a strategic perspective, a lot of the conversations we have are focused on that because, again, they see the value in the data.
Well, then again, we talked about the fact that there are multiple kinds of QHINs. There are like 3 classes. There are those that are associated with the vendor community, 2 of those. There are those that are associated with the HIE community. There are 2 of those. Right. And then there are those that are, kind of in the nonprofit realm. So that's, the Commonwealth is not of that ilk. They're actually associated with the vendors, right? So I look at that. There are commercial companies that are one of the, like we had 2 commercial companies that are trying to do this as a commercial venture. In past, this has not been a commercial venture, really. Right. Like HIEs are almost universally 501c3s. So this is going to be interesting to see if it actually produces enough revenue that it would attract someone like that. Right now, it has attracted 2 commercial companies. So it's going to be interesting to see how that shakes out.
Well, I think some of the early commercial companies that were going to throw their hat in the ring decided we got to be in V2 because they're commercial companies, they're publicly traded companies. They have to answer to their shareholders about this investment is going to get you what, and the economic model of it hasn't really even played out yet. So I think that's definitely going to be a wait and see.
We only have about 5 more minutes. Let me highlight a couple of things that I've heard and learned from y'all today. To move us forward, education on what interoperability is and what tools are already in existence and are about to be in existence are there. There's got to be education. Sounds like it's probably a good idea that there is some type of incentive. Now, I know that their TEFCA access, I'm not sure when, but maybe next year or the year after, is going to be part of one of the promoting interoperability categories. Yep. So that's the beginning of it. But it's always easy for provider organizations to kind of weave and work around those kind of things. So that's not a true incentive. But education, incentives, what else do we need?
I think independent certification for the players in TEFCA is going to be important, and establishing a bare minimum bar.
Minimum bar.
Because that's in the absence of that, the market won't solve for it because it's not the QHINs will be disincented to offer it or to require it.
What kind of certification are you talking about?
Adherence to a framework.
Okay.
That is defined for a specific stakeholder type. So as opposed to no bar at all. So basically, just knowing that that they're doing the right things by their cybersecurity requirements, that they're taking the right care of their user experience in terms of authentication and such. These are really important things to manage. And if you have no rules about that, then you're basically saying that the QHIN is going to be responsible for that because they have the obligation. Right. That sounds good, but again, they're going to be disincented to do it if it means they have to charge their participants for something that not everybody has to do.
Gotcha.
And I think, just look at the topic of our conversation today. Is adoption the last hurdle? Well, yeah, of course adoption is our last hurdle, but there's a lot to unpack because what we're asking is for big, huge institutions to change, and we're asking for small individual physician practices to change. And we're asking this whole industry to change. And so we have to get to adoption. But how we get there is really a collaborative, a governance, and it's a framework that, TEFCA isn't the magic bullet to make that happen. So I think a lot of conversation and a lot of tests and a lot of, proof, and then you create some sort of a blueprint. But we have to measure what seems to be working, what doesn't seem to be working. Why is this particular stakeholder not adopting?
Right. Exactly.
And then we can hopefully get there. I have hope. Let's just say. While I'm still in this business, I can say.
And there's a lot
Right.
of potential. We're almost out of time. Michael, give me 30 seconds. What else we need to do?
Validated assurances. That's what it's all about.
Okay.
Validated assurances is part of the overall ecosystem.
Okay.
I think to Scott's point, QNs I think are going to try to be good stewards within this equation, but there's only so much that they can do from an enforcement perspective around participants and sub-participants. Validated assurances are critical.
Well, great. Y'all have taught me a lot today. Bevey, Scott, and Mike, thanks for joining me today. I'd like to thank certainly our sponsor, Consensus Cloud Solutions. Thanks to Chime and DHI for allowing us to use this stage, and thanks to the audience in the theater and on the video feed for joining us. I'm Jim Tate, and thanks for joining this special edition of the Tate Chronicles. Thanks, guys. Thanks.